Perfect. So let's move, and Elmar Joura from Austria will take over for the next chapter. And I want to thank all the speakers for this wonderful presentation. And you are perfect, have been in time. It's not easy in such a topic. So Elmar, that's your turn.
Thank you, Jalit. Was a great first session, and I hope we have an exciting second session. So we have speakers from the US, from Africa, from India, and also from Europe. And we have assembled top experts, so it should be quite a great session. And I'll start with my first presentation on new vaccines which will come on the market in the next few years. And I'll briefly start what's available now and which HPV vaccines are WHO pre-qualified. What are other vaccines which are already on the market or are in phase 3 trials, and then conclude the whole topic. So Africa is a hotspot for cervical cancer, and we have especially the problem in sub-Saharan Africa that we have a high rate of HIV, and HIV makes a six-fold risk for developing invasive cervical cancer compared to those women being HIV negative. So the vaccines we have available and which are commonly used is the bivalent vaccine Cervarix by GSK, protecting against 16 and 18, and we have a good cross protection against three other types, which is probably waning over the time, but it's important for Africa that HPV 45 is the third most common type in Africa. So it's important, but cross protection has not been demonstrated with a single dose. So this is certainly some caveat. And you all know Gardasil, the quadrivalent, which includes HPV 6 and 11, preventing also genital warts and low-grade lesions. And this vaccine is perfect for gender neutral programs. So to briefly tell what's important, the most important thing is certainly prevention of HPV 16. More than 50% of invasive cervical cancers are caused by this type, and more than 90% of non-cervical HPV-related cancer. HPV 18 causes 50% of the adenocarcinomas, which is usually tricky to find and even more dangerous than squamous cell carcinomas. And then we have a variation over the regions, which is the number 3 in Africa. It's HPV 45, also causing approximately 10% of adenocarcinomas. What we also have to be aware is that in young populations, and in Africa we are mainly speaking of young population, it's predominantly HPV 16 and 18. The other types become more important later in life. And when we talk about gender neutral vaccination, men only get disease from HPV 6 and 16 if you want to develop such a strategy. If we talk about HIV positive, so they are more susceptible, and in these populations, multivalent vaccines are preferred. So what's important? These vaccines really prevent invasive cancer, and you all know this curve comparing young Swedish women. The unvaccinated are the orange line, and the early vaccinated, and that's also always important to highlight. It's important to vaccinate early. Then the green dotted line remains almost at 0. And what's also important, we have now these vaccines for almost 20 years in use, and WHO confirms that these vaccines are really safe, and they also have no adverse event to fertility or to pregnancies. So probably the best vaccine available is the 9-valent vaccine, which adds 5 other types, oncogenic types on top of HPV 16 and 18, which covers more than 90% of invasive cervical cancers. So let's move to the new vaccines. There's a lot of things going on in China. Here you see a list of vaccines which are in phase 1, 2, or 3 trials, and what's already available and on the market, at least in China, is a bivalent vaccine, Zecolin. It's based on an Escherichia coli production, which is quite cheap and easy to make. So this might be very a cost benefit, and this vaccine is already WHO pre-qualified. And then there's a second bivalent HPV 16/18 vaccine from China, which is produced on yeast. This is also WHO pre-qualified. And in a comparison of the immunogenicity, it has been shown that 2 doses, like with other vaccines, at a young age produce higher antibody levels than 3 doses later in life. So it's absolutely comparable in the immunogenicity with those vaccines which are already on the market. India has a quadrivalent vaccine, which is not yet WHO pre-qualified, but it's on the Indian market available. It's when you Google the price, it's not as cheap as we would hope, but this might be quite different in a program. And just 1 week ago, a 9-valent vaccine, Zecolin 9, from Innovax was licensed by the Chinese authorities. And in a comparison with Gardasil 9, it demonstrated quite favorable results, but we'll expect the end of this study by the end of next year. So what's now in development in phase 3 trials? There's an 11-valent Chinese vaccine. They add HPV 59 and 68 to this vaccine. There's an ongoing trial in more than 13,000 women aged 18 to 45. It's placebo-controlled, and we expect the data by the end of 2028. At the same time, when we also expect data from these 14-valent vaccine, which adds, and this is important, HPV 35, because we've seen in South Africa, especially in HIV-positive women, quite a number of HPV 35 positive cancers. Elsewhere, HPV 35 is not a problem, but certainly in South Africa. So a lot is going on. This will certainly be game changers on the global market. And what's important, aside of efficacy and safety, which is always the most important thing, of course, price matters. It should be below $10, preferably far below $10. It should be available and should be included in robust programs. And also cold chain is always a topic, so it would be great to have vaccines without a cold chain. So far, all these vaccines, they need a cold chain. And at the end of the day, coverage is key. When we have a good coverage, we see herd effects, and gender-neutral vaccination is certainly an important step towards increasing the coverage. and also with a good coverage, we are even safer with a one-dose concept. So thank you for your attention, and we move to the next speaker, Laia Bruni from Barcelona. She's an expert on the coverage of HPV vaccination globally. She has written landmark papers, and also want to invite you for the next ESCO webinar on the 9th of July, when we talk more on HPV from all different perspectives. So thank you very much, and Laia, it's your time to be on stage.
So many thanks, Elmar, and good morning to all. Many thanks for the invitation. It's a pleasure to be here today and discuss the status of HPV vaccination coverage with this special focus on Africa. So let's look at the global map of HPV vaccination. We see that currently 149 countries, that did 77% of WHO member states, have introduced HPV vaccination in their national immunization programs. And we see how in the Americas, Europe, Oceania, over 90% of countries have already introduced, but in Africa and Asia, a significant number of countries, including those with large populations, have yet to introduce. And although there are good news, we are seeing that these last years, there has been a big push in all those regions, in Africa and Asia, to expand introductions. And this has major implications for global coverage, the introductions. As we can see in this bar chart, 20 countries account for 75% of the global cancer burden, with China and India alone making up for 40% of the cases. This is due not only to their incidence rate, but also to the large population sizes. While many countries have introduced HPV vaccination, around 50% of girls worldwide still live in countries that have not yet implemented it. And this is what affects these global coverage levels. 8 African countries are among these top 20. In yellow, you can see highlighted the countries that have introduced vaccination, and some of them have done so very recently, like Bangladesh, Nigeria, Cambodia, or Poland. Of these 20 countries, there are still some that have not yet introduced, but we know that they are planning to do so in these next 2 years. So this brings us to one of the biggest challenges we still face, making sure the HPV vaccine reaches countries that have not yet introduced. But introducing the vaccine is just the first step. The next challenge is ensuring high coverage, as many countries still have low coverages, as we will see. In 2022, WHO recommended the single-dose schedule as an alternative to the multi-dose regimen. Since then, half of the countries have now adopted this approach. On this map, you can see the countries that have implemented single-dose recommendations, and they are highlighted in darker color. In addition, this map distinguishes between gender-neutral vaccination programs and only girls programs. And the gender neutral are shown in blue, and those that vaccinate only girls are shown in pink. And as we can see at level, more than 70% of HPV vaccination programs in Latin America and Africa have now transitioned to single-dose schedule, along with half of the programs in Asia and Oceania. Regarding vaccination of boys, Europe and America are the ones that have expanded it more extensively. In Africa, 4 countries have gender neutral or universal vaccination of boys and girls. And these are Cameroon, Cabo Verde, Mauritius, and Seychelles. So let's take a closer look at the situation in African countries. Over the past 5 years, many African countries have introduced the HPV vaccine, although there are significant sub-regional differences. In Middle or Central Africa, for example, most countries have yet to introduce the vaccine. Only Cameroon and Sao Tome and Principe have done so. Importantly, the majority of African countries have adopted this single-dose HPV vaccination schedule. Of the 32 African countries that have HPV vaccination programs, 23 have switched or they have directly introduced with one dose schedule. Countries that making the switch have followed a variety of approaches, including long-term planning, rapid transition, and the use of multi-age cohorts, the MAX. We expect that more countries will introduce or switch to one dose within this year. In Africa, between 80 and 90% of HPV vaccines are delivered through schools. But countries that rely on school-based delivery also they also offer the vaccine through health facilities and outreach services. So we have mixed delivery systems across the whole continent. Worldwide program coverage remains suboptimal in many countries. In 2023, only 16 countries reached coverage for the first dose higher than 90%. In 2023, the average coverage achieved by programs was 62% for the first dose and 62% for the first dose and 52% for the final dose. And we also need to keep in mind that coverage differences exist not only between countries, but also within them at subnational level. But how does Africa perform? When comparing the average performance of programs across WHO regions, we see that overall, they now perform at similar levels, although coverage still varies significantly. In the Afro region, and the average program coverage for the first dose is 62, and the coverage for the final dose is 52. So this is exactly the same as the global average. With the shift to the single dose schedule and this current 10% point gap on average between the first and the second dose is expected to disappear, since the coverage for the first dose schedule will reflect also the first and the final coverage. So looking more closely at HPV programs in Africa, we observe significant variation in performance. Programs in West Africa generally show lower coverage compared to other subregions. However, it's important to note that Northern and Middle Africa have very few participating countries. So program averages are based on very small numbers. Only 4 countries have achieved first dose coverages about 90%, and a total of 8 countries have reached coverage rates over 80%. However, we must keep in mind that coverage estimates are based on data of varying quality. In some cases, high reported coverage may reflect data issues rather than actual performance. For instance, if a country main target group is, let's say, 9-year-old girls, but eligible age range is 9 to 14 years, and vaccinated data is not disaggregated by age, the numerator may be inflated by including girls outside these 9-year-old girl targets. And this can lead to an overestimation of coverage. Just one moment, because I need to jump to a slide that in this version it's placed at the end, this one. So this is very important, the quality of data. Now we have an increasing number of coverage surveys available to validate and challenge this administrative data. It's essential that these surveys disaggregate data by single year of age as much as possible. And this allows us to assess the impact of early introductions using multi-age cohorts, and also to track trends by birth cohort over time. Here you can see an example, where a survey data corrected administrative coverage estimates by 20 percentage points. So still we need this kind of complementary information, no? Both administrative data, this is very important, but also to have survey data. So now I have to go back, sorry, again. Sorry, yes. But now we have seen no average program performance, this 62%, but now let's take one step further. Until now, we have only looked at the performance in countries that are vaccinated. But what happens when we also consider the population size of each country and include those that haven't yet introduced the vaccine? It's like saying, let's put all eligible girls from all countries together and asking how many of these girls have been actually being vaccinated from all the countries. When we do that, vaccinating and non-vaccinating, the estimated global HPV vaccine coverage for girls in 2023 is just 27%, at least for one dose. This global estimate has been increasing steadily over the years, and this has been mainly driven by the introduction of HPV vaccination in more countries. But we can see also there was a dip during the COVID pandemic. And over the past 2 years, we have seen a strong recovery, and the shift to a single dose schedule has also played a key role in that progress as well. In 2023, we estimated that across Africa, 35% of eligible girls received at least the first dose of the vaccine. This regional estimate includes both vaccinating and non-vaccinating countries and takes population size into account. In practical terms, it means that just over 1 in 3 girls across the continent were vaccinated in 2023. At the sub-regional level, the differences are quite striking. First dose coverage was only 3% in Northern Africa and 9% in Middle Africa, compared to 61% in Eastern Africa and 66% in Southern Africa. These differences are largely due to varying number of countries that have introduced the HPV vaccine in each region. This figure also highlights the upward trend in HPV vaccination coverage over the past 5 years, as well as the disruption caused by the pandemic in 2020 and 2021. The impact of the pandemic also varied across regions, with Eastern and Southern Africa being the most affected, but mainly because there were the regions with most active vaccination programs at the time. So, in terms of absolute numbers, we estimate that in 2023, 28 million girls and 6 million boys aged 9 to 14 received their first dose of the HPV vaccine. This represents an increase of 12 million compared to 2022. Of these, 13 million girls and 1 million boys were vaccinated using a single dose schedule. Focusing on the 13 million single doses given to girls, we find that half of them, 6 million, were administered as part of new vaccine introduction. The most significant increases in vaccination numbers were seen in Africa and Southeast Asia. In Africa alone, an estimated 12 million girls were vaccinating in 2023, which is almost 7 million more than the previous year. And this remarkable growth was largely driven by large-scale introductions in Nigeria, for example, for Africa, and Indonesia and Bangladesh for Southeast Asia. So to conclude, and to summarize, we can say that there are significant differences not only in HPV vaccination coverage between regions, but also in programs performance, both between and within countries. In 2023, we estimated that over 12 million girls in Africa received at least 1 dose of the HPV vaccine, resulting in a regional coverage of 35% for the whole continent. However, this regional estimate, it's pulled down by medium coverage levels and the absence of vaccination in some of the continent's most populous countries. The good news is that HPV vaccination efforts in Africa continue to show an upward trend. Eastern and Southern Africa lead with the highest subregional coverages, 61 and 66% respectively. Still, very few countries are meeting the 90% coverage target. Most African countries are reporting coverage rates closer to this 60%, this average of 62%. So these figures underscore the urgent need to strengthen efforts to improve vaccination coverage across the region and to accelerate vaccine introductions. And finally, it's important to continue the efforts on enhancing the quality and accuracy of HPV coverage data. And this remains a critical priority to guide and to also evaluate these efforts effectively. And that's it. So many thanks for your attention.
Thank you so much, Laia. A great talk as always. I hope we have some time at the end for discussions, and we move on. I'm excited to welcome Nelly Mugo from Kenya, and she will give her experience on the KENSHI trial with a single-dose HPV vaccine. Nelly, please.
Okay. Good morning. I want to start off by thanking ESGO for this invitation. And it's a real pleasure to share with you our data from KENSHI, and an even better pleasure to have listened to the previous presenters who really set the stage for this. So I was asked to talk about the Kenya single-dose HPV efficacy study, and several slides I'm going to pass through because they've already been addressed and I don't need to repeat, and I would like to keep to time. Okay, so I just want to say that I'm an MISP recipient from Merck, and I'm sure you've already seen this, and it's been discussed that our goal for vaccination is 90% coverage of girls by the age of 15 years. So we know that the vaccine is a virus-like particle, and I think we've already had a list, and there are many more different types in the market. But what I wanted to remind us was the vaccine efficacy when we did the multi-dose trials, the proof of concept trials, that the bivalent vaccine demonstrated 94% efficacy against HPV 16 and 18. And you know the intervals between these are very similar. So I just want to say that these efficacies are not very different. And the nanovalent vaccine that has a total of 9 HPV serotype protection also had that range of 94 to 96% efficacy and protection against the vaccine serotypes. I know you've already listened to the Dolly's trial. I'll present the KENSHI trial, but it's a reminder that we had these previous trials from India and Costa Rica that gave us the first inclination that one dose is enough to protect from HPV infection. And more recently, we've had population level data looking at population level of how effective a single dose is in protection against high-risk HPV types that are cancer-causing. So from 2004 is when we saw those early trials, and then to our own data when we started the KENSHI trial in 2018, and which is still ongoing. And then last year, we received this data from Sweden that looked at actual lesion impact with a single dose. So the single dose trials are across continents in Southern America, Africa, and the Asiatic regions. And I'm going to skip this because it's data from other previous trials that was put together and looked at the differences and the outcomes when people had one dose and multiple dose. So my question today was data from Kenya's single-dose HPV vaccine trial amongst young African women. And we have 5 women from the region who've been running this trial, led by Professor Ruan Barnabas, who's the protocol chair, my colleagues, Dr. Mariciana Onono, Professor Elizabeth Bukusi, and Dr. Betty Njoroge are the investigators for this study. So the primary objectives was to test the efficacy of an immediate single dose, nanovalent or bivalent HPV vaccination to prevent incident persistent HPV 16 and 18 infection. The second objective was to test the efficacy of immediate single-dose nanovalent HPV vaccination to prevent incident persistent HPV type 16, 18, 31, 33, 45, 52, 58 found in the nanovalent vaccine. And this trial enrolled 2,275 girls, ages 15 to 20, and were randomized into 3 equal 1:1:1 ratio to either receive the bivalent or nanovalent HPV vaccines, and the control arm was what we call delayed HPV vaccine, and they received the meningococcal vaccine. And we've published data at 18 months showing efficacy after 18 months of follow-up, after 36 months of follow-up, and at IPVS last year, we showed data after 54 months. And this is the data I'm going to present to you today. So we started enrollment in December 2018, and within a year, we had fully enrolled the cohort. 57% were between the ages of 15 to 17, and 61% were between 18 and 20. And the criteria was to have 1 to 4 lifetime sexual partners, and there's equal distribution across the 3 arms. We like to show this slide. And what we look at in this slide is the incidence of non-vaccine HPV types across the 3 arms. And you can see the incident persistence of non-vaccine type of HPV was equivalent across the 3 arms. And this tells us that this cohort was at risk and exposed to HPV infections. So we look at the month 18 data on the modified intention to treat for those for HPV 16 and 18. And in the nanovalent arm, there was 1 incident persistent HPV infection, 1 in the bivalent arm, and 36 in the meningococcal vaccine arm, giving us a vaccine efficacy of 98%, which was highly significant. We also now, for the nanovalent arm, looked at the protection from the 7 serotypes in the nanovalent vaccine. And we can see the delayed vaccination, remember, is the meningococcal arm. There were 29 infections, which is any one of the above. And in the single-dose Gardasil 9, which is the nanovalent arm, there were 4 incident infections, giving us a vaccine efficacy of 89% protection. Then we looked at data again. After 3 years of follow-up, we looked at the efficacy of the single dose, and it remained high and durable with an efficacy of 99% for bivalent and 98 to 99% for both nanovalent and bivalent. And what you can see from this hazard ratio curve is that amongst those who receive vaccine types, the lines tipped flat at the bottom, and the meningococcal control arm, the cases kept increasing as time went by. Then when we look at the next graph, where the efficacy at 3 years of follow-up, when we're looking at the nanovalent arm, we can see again in the vaccine arm, it's a blue line, it remains flat, and the meningococcal control arm, they had 84 infections. Just to be clear, is that if you look at the measles and mumps and rubella vaccine efficacy, it has a 97% effectiveness against measles and 88% against mumps. So this is a highly effective vaccine, and the single dose remained highly effective. So in this slide, we included girls who had tested positive for HPV serotypes at baseline and month 6. And in this arm, we see because this is a reminder for us that the vaccine is prophylactic, not treatment vaccine, and that it works best, and I think the previous speaker spoke to it, when there hasn't been previous exposure. But we said this cohort was sexually active. And it's good to keep in mind that even if you were exposed to one serotype, let's say HPV 16, you may still be naive with no previous exposure to 16. So I've seen this question before. We never test people before vaccination. It's not relevant at all. And this cohort of girls who had previous vaccine HPV serotypes, the vaccine stayed very effective at 88% for the nanovalent and 84% for the bivalent, but the confidence intervals cross each other, and there's no difference between the two vaccine types for HPV 16 and 18. So at this point, after 36 months of follow-up, the DSMB asked that we vaccinate everybody, and we processed what we call crossover. And everybody who had received HPV vaccine then received a meningococcal vaccine, and those who were on meningococcal arm received the nanovalent vaccine, and they stayed blinded. And I'm coming to the close of the hour. I wanted to refer you to these monographs that were published in 2024 last year, which gives you a very good overview on durability, vaccine effectiveness, and screening integration. So I'm not going to go through this, but it tells you, and I think Doris showed this, that single dose has been shown to continue being effective for long periods of time in the observational cohorts that have now been followed up for up to 19 years. And the data on avidity that shows the binding power is similar across the dose regimens. The red is the HPV 16, the blue is HPV 18. So you can see the similarity. And this data, which I think was very, very exciting for me, looked at adolescents receiving 1 or 2 doses before the ages of 17, and was presented last year. And you can see that the single dose continued to stay equivalent at the population level, but that it works best in the ages 10 to 16 when they're vaccinated early. So I think on that note, I can reach the conclusion of my slides so that I can stay within time. These have already been presented. I don't need to show them. These slides will be shared that will show the number of trials which are ongoing, and to say that Merck announced their plans to conduct a proof of concept single dose trial, which hasn't started yet, but we're looking forward to it. So the evidence, I think, is robust that single dose works very well across populations, age groups, and is protective and it has been sustained over time when the girls are vaccinated, I think from 10 to 19 years, and that the bivalent and nanovalent may have lower antibody responses, but they remain equivalent on impact. And we continue to follow up this cohort to look at long-term sustained protection. But I think after 54 months of data, observational data, we remain confident that the single dose is highly effective and immunogenic in protection from the vaccine HPV serotypes. So we require everybody in this battle against cervical cancer and HPV-related diseases. Thank you.
Thank you, Nelly, for your important and absolutely exciting data. So this is a real game changer. And for now, we move on to the next lecture, which was pre-recorded. Anna Giuliano, she's certainly the leading expert for HPV in males, and she will give us an overview on the importance of HPV vaccination of men in Africa.
Thank you very much for the invitation to present. I'll be talking about gender-neutral vaccination and what is best for Africa. And just quickly, I just want to share with you my disclosures. I do a lot of work with Merck, MSD, as well as other companies that are now creating therapeutic vaccines. So to start with, I think it's always important to remind everybody that HPV causes cancer in both men and women. And when we look worldwide, it's very clear why we focus on cervical cancer, because this is the most common cancer that HPV causes worldwide. However, if you look at the next layer above cervical cancer, you see head and neck cancer. Now, what's interesting about head and neck cancers are that they are essentially a predominantly male cancer, where there are 5 more cases of cancer of the head and neck in men compared to women. And the incidence of these cancers that you see for head and neck cancer, as well as penile cancer and anal cancer in men, are all increasing in incidence. And so this is what I'm showing you here on this slide. When we look at the cancers that HPV causes in men, anal, penile, oropharyngeal, and oral cavity cancers, we see that all of them are increasing, and they're increasing in every country where we carefully document cancer incidence data. Now, what's interesting about these cancers in men is that there is a range that's attributable to HPV. So for instance, anal cancer, around 90% of those cases are due to HPV. Penile cancer, it's around 50%. And depending on the tobacco control policies in a country, so for instance, in countries where very few people smoke, we see a very high proportion of oropharyngeal cancers as caused by HPV. So for instance, at my institution here at Moffitt, 90% of those cancers are caused by HPV. But what's most important to understand is, unlike cervical cancer, there are no routinely available screening methods to prevent these cancers in men. So really the only opportunity we have to prevent these cancers in men in any country is vaccination. But let's look at the Africa continent. Now, when we consider Africa, especially sub-Saharan Africa, we find that there is a large prevalence of HIV, people living with HIV. And we know, due to the immunosuppression, that HIV increases the risk of acquiring other infections like human papillomavirus. And they also are at increased risk of progressing with those infections to cancer. So these are data that I'm showing you, courtesy of a good friend and colleague, Scott Dryden-Peterson from Harvard, who's been studying cancers among people living with HIV in Botswana. Now, Botswana has among the highest prevalence of HIV in the world. And you can see here the cancers that are outlined in red. So anal cancer, head and neck cancers, obviously cervical cancer, other cancers in the woman, reproductive tract, vulvar, vaginal, and so on, and penile cancer. And I do want to say that in his data from Botswana, the incidence of penile cancer is actually as high as the incidence of cervical cancer in Botswana. So really highlighting how a lot of these data have not made it to our publications or are not in the classic registry systems. But in these special studies, what we're finding, not only in Botswana, but in Zambia and as well in Zimbabwe, is a growing and high concern about penile cancer increasing in incidence. So the types of HPV that cause these cancers are varied, whether it's cervical or non-cervical. So as you can see here, for cervical cancer, there are 12 to 13 HPV types that we say cause cervical cancer. But when we look at the cancers that HPV causes in men, it's quite simple. So 16 and 18 predominate, both for the penile cancer, anal cancer, oral cavity, as well as oropharynx. So what that means is that those countries that have vaccination programs with just the bivalent vaccine are going to do as well as countries that have, in terms of preventing the cancers that HPV causes in men, as well as, Gardasil, which is also directed at 16 and 18. So for men, it isn't necessary to have to use a 9-valent. So the programs that currently exist in Africa, which are predominantly Gardasil programs, would work very well to prevent the cancers that HPV causes in men. So what is going on with HPV in men? Well, in work that we've done in Latin America, what we find is that men have a higher prevalence of anogenital HPV than do women. So the bars represent the men in our study, and the lines represent female data from countries, the same countries that we were working in. And it becomes very clear that 1, the prevalence is higher in men, and 2, that prevalence remains constant across the lifespan. We did our study among men ages 18 to 70, and we did not see variability in the prevalence across that age span. The other thing that we find is that men seem to remain susceptible to acquiring a new HPV infection throughout their lifespan. And the reason for that is, unlike women, they rarely develop a protective immunity after natural infection. So what I'm showing you here, and we could just focus on the table. If you look at women, and let's take HPV 16, around 60% of women will develop an antibody against HPV after infection, but less than 4% will among men. And that's very clearly illustrated here in the turquoise line. You can see here how low the seroconversion is in men. So as a result, not only do very few men develop the antibody, but when they do develop the antibody, it does not provide protection against reinfection with the same type. And in fact, what we have observed in transmission studies in our work, as well as what others have observed in their transmission studies, is that the transmission from women to men is much higher than the transmission of HPV from men to women. So this is the opposite of what we typically think of sexually transmitted infections like HIV. So altogether, what we say is that men do experience a high burden of infection and related diseases. And the disease incidence and infection incidence remains constant throughout their mid-adult years. So they're really what I consider a very susceptible and vulnerable population. They rarely develop immunity following infection, regardless of age. And when they do develop an antibody, it doesn't protect them. We find that the incidence of some cancers like head and neck cancer are 5-fold higher in men than in women. And in countries like the US, where we have good screening programs for the cervix, the incidence of oropharyngeal cancer is higher in men than the incidence of cervical cancer in women. While women, female-only vaccine programs do provide herd protection for heterosexual men, it does nothing for older men who are not interacting with those vaccinated women, or for men who have sex with men. They all remain unprotected. There is limited access to cancer treatment in Africa. And so for the cancers that HPV causes in men, we find that the treatment possibilities are low, and therefore morbidity and the mortality due to those cancers remains very high. And so really the only thing we have is vaccination as the only reliable way to ensure protection against these cancers. So vaccinating males along with females also is an important issue around equity. It provides better coverage, and I'm going to show you some of those data on herd immunity, negating a lot of the structural barriers that occur with reduced coverage in females. It does prevent cancer in both males and females. And really, it's the only way to quickly eliminate all the cancers that HPV causes in men and women. So what I'm showing you here is the worldwide incidence of cervical cancer. And you can see Africa really stands out as having a very, very high incidence. So let's say a country only cares about reducing the incidence of cervical cancer. Is there a rationale for going to a gender-neutral vaccine program? Well, as I mentioned earlier, you see here now the map of HIV, and again, Africa really stands out. So we have an especially high incidence of cervical cancer and HIV in the same populations. So there are going to be some extra challenges in achieving the elimination goal, which is to reduce the incidence of cervical cancer to less than 4 cases per 100,000. And you can see here the targets, the strategy that the WHO has developed. And that includes 90%, and this is sustained 90% vaccination of individuals by the age of 15. And then you can see the screening and the treatment guidelines. But let's just focus on that 90% and the challenges in achieving that, even if it's just a female program. Now, if it can be achieved, we're seeing wonderful effectiveness, meaning that we know the vaccine works. And all I'm showing you on this slide is all of the countries that have reported population level effectiveness of the vaccine against infection, genital warts, intraepithelial neoplasia of the cervix, as well as cervical cancer now. And this does include countries in Africa, for instance, Rwanda. Okay, but where do we stand with vaccinations? So the strategy is 90% vaccinated by age 15. So if you look at high-income countries, we're doing fairly well for women. We're reaching around 88%. These are all data. It's improved somewhat since this time, but we're reaching a large proportion of the females in high-income countries. But Africa is a continent of mainly low and middle income countries. And you can see here, we're doing a very poor job reaching a large proportion of women in those countries, only 40%, and even smaller for males. So what does that mean for programs moving forward? Well, not only are we only reaching a small proportion, but we don't have immunization programs in every African country. So I think the primary goal is to get a vaccine program in every African program, in every African country. And the other is to, once that's established, is to really develop a mechanism to reach as many people as possible. Now, for the countries that do gender-neutral vaccination, what we find is that the uptake in males is equivalent to the uptake in females, that there aren't any cultural or concerns about vaccinating males as well as females. In fact, I think it really takes away the concern of why are we only targeting females when we know this infection causes cancer in both. We also know, and we've had the horrible experience of the vaccine interruptions due to the COVID pandemic. That's not the only reason that there have been vaccine interruptions. You know, we've seen this in multiple countries around the world. Well, if you have a female-only program and there is an interruption, there is a reduction in the percent of the population that's covered and protected. Whereas if you have male and female coverage, you can see that the protection is much greater. So you don't lose as much. Also, cervical cancer elimination is going to be much more rapid if it's both a female and a male vaccine program, as I'm showing you here. So the time to elimination is going to be a lot faster if it's gender neutral with high coverage for both. Now, I just want to remind everyone, it is hard to achieve 90% coverage. I think what's reasonable is 60% or higher, and you can see that it's far superior to what is happening in most countries where they're barely at 60% coverage in a female-only program. So again, if you only care about preventing cervical cancer, it makes a lot of sense to have a gender-neutral program. But if you care about really eliminating these viruses and all of the cancers that these viruses cause, you need to focus on HPV-16 because the behavior of this virus is particularly bad. It has a higher rate of persistence and a higher rate of progression. And it is the one most important type that causes all of the cancers in males and females. And what this modeling exercise shows is that if the vaccine program is gender neutral, we can achieve elimination of these viruses in 40 years versus 70 years if it's female only. So to conclude, HPV vaccination of males and females demonstrates strong efficacy against infection and disease. I didn't show you this, but I'm telling you now that long-term follow-up cohorts show us that there is no breakthrough vaccines, vaccine-related infections or disease in either males or females. And right now we're up to around 50 countries that are gender neutral. In countries that do have those programs, male and female vaccine uptake is similar. So why go with a gender neutral vaccine program in Africa? It's an opportunity to more rapidly eliminate cervical cancer and other cancers in males and females. It provides equity. It provides resilience against vaccine interruptions, as occurred with the COVID-19 pandemic. And it provides direct protection against disease to heterosexual males, so they're not dependent on remaining in the herd for protection. And it's the only way to have vaccine protection against disease among men who have sex with men. And with that, I thank you.
So thank you, Anna. Regards to Florida, great as always. And we're moving now to our last presentation from India. It's about a self-sampling collaboration between India and Norway. So we're excited to learn about this, and we have also a question in the chat about urine testing. Maybe this can also be addressed during this talk.
Thank you so much. Am I audible? Hello?
Yeah.
Yes.
Yes, you're there.
Okay. So can you move my... Yeah. So thank you very much for giving us this opportunity. So this is the second session of the day, and thank you, Dr. Murat. So this will be a very interesting presentation about community-based cervical cancer screening, and this was through home-based HPV test in Orissa. So this is a state in the eastern part of India, and in which we actually took it as a pilot project. And this, my disclosures are that it is a government project supported by Norway-India Partnership Initiative, and I have no financial support for this except that I was a technical advisor to them and did all the management after they were detected. So here you can see that the India cancer rates have been going high in spite of all the methods that we are doing. So in 2022, we had 1,27,000 new cases and 79,000 deaths per year in India. So we had a rising trend, and 6,60,000 new cases of cancer cervix are added every year, and among them 3,50,000 deaths take place worldwide. And India contributes sadly 1/4 of all the world cancer burden, along with China, of course. So going to meet the 90-70-90 by 2030, which is the WHO's call. So we have the updated guideline on screening and treatment of pre-cancer lesions for prevention of cervical cancer, including all women with HIV. And so the cervical cancer elimination initiative actually tells us that we have actually are moving from cytology and VIA to HPV based screening, which is a high performance alternative. And in this we have a screen and treat approach, which has to be which we can do without any triage, but except for HIV positive women. And the other one could be a screen, triage and treat approach, and we can triage with genotyping, with VIA, with cytology. So these are the options that are given to us by WHO. And more than that, there is a recommendation on HPV self-sampling by WHO. And when providing HPV DNA testing, WHO suggests using either provider or self-collected samples. And this is the only means by which actually we can reach the unreached people, the last mile, the last woman who can never ever come to the hospital for screening. So Norway-India Partnership Initiative, this is a health initiative between Government of Norway and India, initiated in 2006. And the vision was to provide catalytic, strategic and innovative support to national health mission and state health societies. So here you can see this is Odisha, which is on the eastern part of India. And NIPI actually works in many states, but I am placed here in Odisha, where we did this study with the help of NIPI. So the background was, this is the second most common cancer, and India contributes to 1/4 of the global cervical cancer deaths, with 1.6% cumulative risk of developing cervical cancer and 1% cumulative death risk. And there is a growing incidence of cervical cancer in my state, Odisha. The proportion of cervical cancer cases among females is second highest, 23.66% in comparison to other registries. And there is a poor coverage of cancer screening and registration, the low coverage of screening rates and cancer registration in comparison with the other NCDs. And there is a definite delay in early diagnosis and management, because still majority of the cervical cancers are being detected in stage 3 or higher, leading to high mortality rates. So then shift in care. WHO recommends the approach to cervical cancer screening. So HPV DNA based test, and why HPV DNA testing? So HPV DNA based test is the preferred method. HPV DNA testing detects high risk strains of HPV which cause almost all cervical cancers. HPV DNA testing is an objective diagnostic method. It is more cost effective when actually you have a platform in place, and samples can be collected by women at home, and this is the biggest advantage. And testing is much simpler than the current approaches, prevents more precancers and cancer, and saves more lives than VIA or cytology, and will help us reach the global strategic target of 70% testing by 2030 faster if access to commodities are available. So the aims were to improve coverage of cervical cancer screening and to know the actual prevalence of HPV infection in urban slum population. The pilot was done under the leadership of non-communicable disease division of Orissa under the NHM. Expert support and guidance was provided by my institute under my leadership, and implementation and technical support were provided by NIPI. So this is the geographical coverage. Here you can see that this is the state of Orissa, and this is the part of which are the two parts which we have first taken up for the study. So one is Cuttack and the other is called Bhubaneswar. So here we did the line listing of how many slums are there, total slum population, and who are the targeted beneficiaries. This was the first step which was done, and it was consisted of a preparatory phase, an implementation phase, and an evaluation and report sharing phase. So we did the line listing of beneficiaries. This was done on a implementation was done on a campaign mode, and then finally we did the testing and then follow up and management of the positive clients. So for this, actually, we made all this IEC material was done, and all this format were created so that all the data could be collected very nicely and completely. And this was a small video that was actually created. We could explain to them
human papilloma virus परीक्षा ପାଇଁ नमूना संग्रह करिवे एही वीडियो रे आमे सिखिबा किपरि घरे निजे.
So this was a small video which was created to teach the women how to collect the samples themselves. And then this is the implementation framework. We go to the community, the ASHA worker actually who is a helping hand for each of the lowest health systems in our country. They go to the home, explain to the woman how to collect the sample. They get the sample, and the sample is then transferred to maybe a primary health center first, and then to the laboratory, which was actually a university hospital in a biochemistry department, where we had the Cobas 4800, and the result was finally again delivered to the PHC. And if she was negative, she was called after, told to come back after 5 years. If she was positive, she was again called back and done the necessary triaging and treatment as was necessary. So roles and responsibility metrics, there were personnel which were called ASHA workers, and they worked at the community level. They had population enumeration, generate demand for screening. All this work was done by the ASHA workers, and there was resource requirements, line listing format, IEC material, videos, pamphlets, all were created, and there was orientation and training programs were done multiple times for the ASHA workers who were actually the crux of the program, who actually learned from us, traveled to each of the homes and collected the samples from them. And there were data entry operators at primary health centers. There was client registration, QR code assignment, and administrative rights were taught. There was line listing of beneficiaries and digital application, client registration, digital application, and database management. So all this were done. Then we had technicians and pathologists, and in the health laboratory, they did scheduling of the testing, sample storage, result notification to the clients and ASHAs, and HPV testing machines were there, administrative rights to application, and human resource, and cervical cancer HPV testing and reporting mechanism was there, and digital application. And finally, the ANMs and the nursing staff, this is the health facility. They carried the patient to the health facility if she had a positive report, and then the procedures were actually carried out according to the triage report. So most of them who were eligible for ablative method were ablated immediately, and who were not eligible for ablative method were referred back. So the HPV sampling was done for all women more than 30 years of age, according to the WHO guidelines, and we use the rover sampling for self-sampling, though this is actually for provider sampling, but we used it and did not have any problem in that, and they were told to put the sample inside the kit and close it tightly and hand it over to the ASHA worker. So sample preparation was then done. So this is how, and this is how the ASHA workers went home to home and explained to the women, gave the kit, collected the sample, and these were again some of the pictures for that. And the ASHA trainings were done multiple times. We took feedbacks from them actually as to what was the problem that they faced when they went to the home, and what was the problem they faced, because there were many women who did not really want to take this test, but they had to explain to them as to what are the goodnesses of doing this test. So it was a very challenging thing, but then we were able to actually do it. And then the ASHA worker actually carried the sample to the laboratory, where they deposited the sample along with all the forms filled up And finally, this was the department where the test was done, and this was done on a COBUS 4800 platform. And this was again tried with artificial intelligence aided visual inspection of the cervix by a machine called a smart scope, in which 5% acetic acid was used, and the images were recorded on a bigger screen, and helped us actually tell whether it was anything to be worried about. And then this was the machine which we used to ablate the cervix when there was a lesion which was seen clearly on the ectocervix. Otherwise, the patients were referred for further treatment at a higher center. So these are again ASHA worker training programs which were done time and again. So these are the two places where Cuttack has already been finished, and according to this, we are actually trying to scale it up to other places in our state. So this was the final results that we got. There were 37,840 women in the slum, and 17% of this, that is 6,436, were eligible women for screening. And out of this, 76% actually took the test, that is 4,896. And this were the women who were screened for cervical cancer. And out of this, we had a 7% positivity rate, that is 322. And HPV positive were identified in the form of 16, 18 or other high-risk types. And out of this, till now, 135, that is 42%, have been offered treatment. So I think it is a very optimistic study, because we could see that we actually went ahead of the 70% goal which was given to us by WHO, that 70% of the women should be screened. So when we took a small community, by self-sampling, we could actually reach and screen 76% of the women, which is higher than the WHO 2030 targets given to us. So looking at this, I think we were very, very optimistic that we can really do it. And 135 screen positive patients underwent VIA. 110 patients were VIA negative, who were advised re-screening after 12 months. And 25 were VIA positive. 15 of them had lesions eligible for thermal ablation. And for the rest, 10 patients, colposcopy and cervical biopsy was done. And one was diagnosed to have CIN3, for which she underwent corization. Two had CIN2, for which LEAP was done. And one had invasive carcinoma in the early stage and underwent a radical hysterectomy. One had CIN2 but underwent hysterectomy outside somewhere without consulting us. So, and I think this is again a flow chart which shows the same thing, how we treated all these women. So this was a very, very optimistic trial. So summary and conclusion is that ASHA has played a really a major role in this pilot study. The choice to be able to do self-sampling encouraged women to access more screening and treatment coverage. The screening rate was 76% and the prevalent rate of HPV was 7%. 42% of the screen positive women received treatment. So the strength was that this is a pilot study. This is a very optimistic study and could actually be the way forward. And looking at this study, actually, many of our areas have again started in India. Also in Banaras, we have started this study. In Orissa, we have started this study. So HPV self-sampling is going to be the answer to HPV screening and HPV cervical cancer screening. So this increases screening coverage. Self-sampling can help reach people who are under-screened or have never been screened. It reduces the barriers. Self-sampling can remove barriers that prevent people from participating in regular screening programs. This is more comfortable. They can do it in the comfort of their own home. It is equally accurate. There is not much difference when done by provider collection sample. Self-sampling is equally accurate to clinician sampling, especially for assays that are using nucleic acid amplification techniques. So these are some of the clinical trials which have also supported self-sampling. And this project was very appreciated by the Norway embassy, by Miss May Ellen, who was there to actually look on this study by herself. But then I was not happy. I was also appreciated very much by her, but I was not happy because we had not been able to give treatment to all the HPV positive women. So that is the problem which I've heard all other speakers also tell the same thing, that we need to build our infrastructure to give treatment to the screen positive women. So the lessons learned: connect with community, teach by example, HPV infection is a taboo for many of the women. They took it as a huge stigma, and linking with treatment is very, very important. And screening does not save lives. It is treatment that will save the women from cancer. And navigation has a huge, huge problem. We need to bring them into the treatment modality and treat them. So I think I should rest my case here, that it is in our hands that we give a smile to these women. Thank you very much.
So thank you very much for this wonderful lecture. I think self-sampling is an important step to improve the coverage also for screening. Unfortunately, we are now with our session over time. Thank you all the speakers for the great presentations. Thank you for the audience. We've received many very enthusiastic commentaries in the chat. We already tried to answer a number of questions directly in the chat. The coffee break starts now. We are back at 11:45 European time, and feel free to contact the speakers, including me directly, if you have a specific question. We'll be very happy to answer them in the chat. And have a great day. Thank you very much.